think we're ready to begin then. Thank you. We'll take the slide down so you can see all the members. There we go.
Great. Well, I will jump in. I want to welcome everyone to another meeting of the Community Vaccine Advisory Committee. I want to thank all of you for your commitment, engagement, participation in this process so far to date. And we have lots of material to discuss today. So I want to jump right in. I want to also give an opportunity for my co-chairs to offer a brief welcome as well.
Great, thank you so much, Nadine. Good afternoon, everyone. Thanks again to all of you for all your time and effort, and as Bobby often points out, incredible attendance record. We really appreciate the ongoing partnership and feedback. I think before we jump in, there's a couple kind of just key updates that I've been asked to follow up on as far as some questions that have come up. I know one burning question has been about the Moderna lot that we had put on pause. I think we can mention now where the scientific safety work group met last evening, and we have gotten input from several other partners, the CDC and others, some allergists that joined us and working on some statements, but I think we are likely able to release that pause. So we will be issuing a statement very soon on that as well. Essentially, there were some episodes of angioedema, and the written statements will have more details, but wanted to let people know that, you know, again, it's so important to get vaccinated, and that the important things that happened in this situation is that the right protocols were in place, and all the individuals have been are home and well. And so more to come on that and more statements on that. And then there's a lot of questions that come up about the pharmacy partnership as well. Part A, our understanding of how that's going is that they will be done with the skilled nursing facilities very soon. And then part B, which is the long-term care facilities, there are 17,000 facilities in California. Our understanding is they are still on target to finish going through all those facilities by mid-February. We are working really actively with when there are communication issues, either with local health departments or the facilities themselves, trying to connect them with our contacts at CVS and Walgreens. We are also working with them on some of the data issues and reporting to make sure that the doses that they're administering are getting into the data systems that we and the CDC and others are looking at. You know, we recognize that with that, there were some challenges at the start, but, you know, we are actively engaged with them and trying to improve that program over time. So those are just some key issues that I was asked to kind of update people on as well. Oh, and the last thing, I also do want to highlight, just there's been a lot of questions about a newer variant that has been noted here in California, also noted earlier in 2020 and in other states and countries. A few of our colleagues that do genomic sequencing or fingerprinting have noticed what we call the L452R mutation in the spike protein. Cedars-Sinai is also calling it the Cal20C variant, and it's very early in our understanding of this variant and what it means for California, but we're actively working again with all of our laboratory partners, the CDC, our local health departments, and others to investigate this and understand the impact of this variant. But so far, there's no evidence to say whether it is more transmissible or not. It is different than the UK B117 variant, and it is also too early to make any conclusions at all. But we do believe that vaccines should still work against this variant, and we don't have any evidence right now to point to otherwise. So those are some other key updates from me. I'll turn it back over to Dr. Burkeris.
Thank you so much, Dr. Pan. And I think now we'll have Bobby walk through our meeting protocols.
Great, thank you everyone and welcome. I just wanted to remind everybody that we'd like to have you, if you're a member of the committee, to have your camera on so we can see you and act like we're in a meeting together somewhere in California. please use the hand raise icon to let us know that you'd like to speak, and we'll call on you during the discussion sections of each portion of the agenda. I want to thank our two ASL interpreters, Katie Sales and Vicki Kennedy. They've been with us almost since the beginning, and we really appreciate their commitment to working with us. We also have closed captioning for members, and I believe, as everyone knows, we have a public listen-in telephone line in English and in Spanish, and we also are live streaming on YouTube the meeting today. Public comment has been taken, and we will discuss it in a few minutes. And you can see the email address there where anyone in the public can send comments that will be distributed to members of the committee. And as always, if you have any Zoom technical issues, if you'll put them in the chat box, we'll do our best to help you resolve them during the meeting. Thank you.
Thank you so much, Bobby. And now as we move forward, I want to open with a few comments about what we are hearing in terms of how things are going with the vaccine rollout. And the short answer, the highlight here is that we hear you. We have been hearing from the public. We've been hearing from our healthcare providers. We've been hearing from our local health officers. We've been hearing about some of the challenges that folks are experiencing, some of the confusion about when folks should sign up, or difficulty actually getting appointments, and really wanting to get further clarification and understanding about how to best engage in our vaccination process here in California. And one of the things that we are hearing in the loud and clear, and that we recognize about the current challenges with our vaccine rollout, is that there's a great need for simplicity and clarity, and that we really have to look at consistency and clarity statewide as we are looking at our vaccine rollout. And so we are currently in the process of really evaluating how we can improve our process, how we can strengthen our process, and we would like to get your feedback and your input and suggestions today in this meeting to help us in that process. And so I will, as we focus and dive in on that in this meeting, we want to start by once again level setting in the data that we're using, the data that's driving a lot of our thoughtfulness and our decision making, right? So level set in that place, and then work together as we look at some of the challenges that we're trying to solve for, to gather your input into that process. So I will turn it over to my my colleague, Dr. Tomas Aragon, the Public Health Officer for the State of California and Director of the California Department of Public Health. Dr. Aragon.
I'm sorry, I was on mute. Good afternoon, everyone. Are we going to go to the next slide? I'm not sure if
we can go to the next slide. I did want to cover public comment. Public comment whenever you'd like to do that.
Yeah. So what I'll do is I just want to say welcome to everybody. We're really happy to spend this time with you to get feedback. A little later in slide 6, I'm going to go ahead and just give you a summary overview of how we're thinking about the issues. Actually, why don't I go ahead and do you want, Bobby, can I just go ahead and do that now?
Absolutely.
Okay. All right. That's fine.
That was my bad.
It's okay. So, we've been getting a lot of feedback. That's one issue. The second thing is that, we have been in the middle of this unprecedented surge that's had a tremendous impact on infections, hospitalizations, ICU admissions, and deaths. And when you look at the data, and Erica is going to go through the data very, very carefully, you will see that it really made us, it forced us to really hyper focus on how can we address this issue, because the people who are impacted the most are not just people who are older, but persons of color coming from communities that are impacted. And we're thinking, how can we use the epidemiologic data for us to be more effective in our vaccine strategy, at the same time really integrating goals with what Dr. Burke Harris just mentioned, which was really simplicity and clarity, where it's very clear to us exactly what we have to do. And there are really four major areas, four major thematic areas. One is an age-based approach that we've already began to articulate. The second major area is really strengthening our health systems, including clinics in the community that can reach highly impacted areas. The third area is supporting our local partners around community engagement and dealing with all the issues around vaccine, doing targeted outreach, getting people to come in, going out and getting people vaccinated for those people who may not be able to access systems for a variety of reasons. And then the last area is the issue of data. It's become clear to us that we do not have visibility on exactly what is happening across the systems that are delivering the vaccines and how it distributes out across the counties. So there is a big push and a big effort to really get the data systems improved. And you may have been hearing about some of those areas. So those are the four thematic areas. And again, I just want to emphasize is that we become really hyper-focused on how do we save lives? How do we do it in a way that's simple to roll out with absolute clarity? I'm going to hand it over to Dr. Erica Pon, that's going to cover the epidemiologic data to really give us all a shared understanding of how we're thinking about it and why an age-based theme is actually very important. Dr. Pon?
Okay, thank you very much, Dr. Aragon. Next slide, please. So as mentioned, and as all of you, of course know, we have been really in a really serious surge since sort of the gradual increase started in November, really escalated in December, and has sort of, we hope and think, may have peaked right after the holidays. We're still waiting to see, just a little bit more kind of which direction things are going, but there are some good signs actually that that the cases may have peaked and that some of the hospitalization numbers and ICU are stabilizing or decreasing. That being said, as you all also know, our hospitals are full beyond capacity. We are monitoring very closely our percent intensive care unit capacity and healthcare staffing and surge, and we still have over 2,500 additional healthcare staff deployed from state and federal resources across the state. So as Dr. Aragon was saying, we've really been in a very serious healthcare system overwhelm and trying to do as much level setting across the state as possible of that. But this slide just sort of shows you, compared to the July surge, which seemed really big at the time, we've had a much bigger surge more recently. Next slide. And then this is just kind of an overview of, again, the peak comparing July to more recently this past winter, November, December surge in hospitalizations. And the dotted line is the intensive care unit as well. This is sort of total hospitalizations, and you can see that's largely proportionally from the COVID positives. And again, thankfully, overall, we're seeing some decreasing trends, but it's still just starting to decrease, and again, is currently still an overwhelming number in our hospitals. Next slide, please. So you all have seen these before, but just to reiterate kind of nationally what we see as far as differences in hospitalization and mortality by age. And this really highlights kind of working backwards by age. Those people 85 years or older have a 630 time higher death rate compared to the comparison group of the 18 to 24-year-olds. And then the over 75 years of age have a 220 time rate higher, and then 90 time higher mortality rate for 65 and up. And again, these are dramatic, especially for deaths. I think you can also see a huge increase here of hospitalization rates for over 85, over 75, and then over 65 compared to the comparison group. Next slide. And continuing again to look at cases and hospitalizations and deaths related to race and ethnicity. Again, nationally, we're seeing a much higher rate of Latino and Black persons compared to others as far as deaths and hospitalizations as well. You can see a disproportionate, again, in our American Indian and the Black and Latino populations. Next slide. So this is actually California data. And again, just to show you as far as the cases, so I was focusing on those others with national data. As far as cases, to emphasize here that 55% of the cases are actually Latino. And you can see they're disproportionate to the vertical line there of how many are in the California population. So that is one of the most dramatic impacts here in California. So I wanted to highlight that part. And the next slide. And then this also for California data, you know, again, you can see this is the different peaks that we've had in California and how dramatically different by age the mortality rate is. So you can see the bright green is the over 80, the next line below that is 71 to 80, and then below that 61 to 70-year-olds. So much more dramatic deaths as far as who this pandemic has impacted most severely. Next slide. And then again, looking kind of in a different way based on race and ethnicity and mortality. And again, the huge peak has been in this December peak. And again, our Latino population, our Native Hawaiian and API population have had the highest disproportionate impact, especially during this peak. And then, you know, you can again see across the board as a peak that we're having this big surge in mortality as well. Next slide. And then, you know, just to reiterate again, as far as both deaths by race and then age, and here's where you can see as far as disproportionality again, the Latino population, 46% of the deaths and disproportionate to the California population, and the African-American population, you know, also disproportionate compared to, you know, others. Whites and Asians are actually lower than the California population as far as the deaths. So again, having that higher impact. And then to call your attention again to the 65 plus, 75% of the deaths on this graph are in the 65 and older. Next one, next slide. And just in one other way to just really, you know, hammer this point home, we have been breaking down our data in the decades rather than the 65 versus 75. But if you look at all ICU admissions, 65% or about 2/3 of them are people 61 years of age and older. And then 83% of all deaths are age 61 and older. Next slide. And then this is just kind of highlighting for you that we have been updating our vaccine website at covid19.ca.gov. And we have more and more data and tools here that you can follow along with. Next slide. And then I think, you know, just to circle back to the points that Dr. Burke-Harris and Dr. Aragon were making, you know, as we've tried to initiate the rollout here in California, hearing a lot of feedback. So again, as you all know, we started with what we call phase 1A, which is healthcare workers and residents and staff in nursing homes, which is approximately 3 million persons overall. And then we are estimating now that about 65 people 65 years and older comprise about 6.2 million people in California. So if we have a goal, in addition to our phase 1A, of getting to the next, again, the people that are most disproportionately impacted, the people that are in the hospital and or dying from this disease, and if we wanted to get at least 70% of them as a target vaccinated, they would each need 2 doses. We would need over 8.5 million doses. The current allocation in California right now is about 4 million. And we're getting anywhere from 400 to, in a good week, 500,000 doses a week. We don't know when that supply will be increasing, but that's kind of been about what we've been getting. So again, in a huge state of 40 million people, we're only again getting about 400 to 500,000 doses a week. So it's going to take us, we're estimating anywhere from 20 to 22 weeks to actually get through just 65 years of age and older. And with the scarcity of supply, combined with again, who is most impacted as far as hospitalizations and deaths, and also a lot of the confusion that has arisen around, even within the healthcare worker population, like who's in the different tiers. We've been hearing a lot about, as far as operationalizing that's sometimes been a barrier to getting vaccine out quickly. And of course, what we all need to get to collectively is as much vaccine in arms as possible. Next slide. And I also just, again, throughout this pandemic and throughout this process, working with all of you, we again want to have, we're here with you for some transparency, but some of the challenges we're feeling. And I've already talked to you about the safety issues, and then equity, again, is front and center. So, we all want to recognize that a lot of the work we've been doing at the drafting guidelines work group and with this group in thinking through who is disproportionately impacted and thinking about it by occupation. The other way, and we presented this to you in the past, but to kind of reiterate, look at who and where we look for people who are disproportionately impacted and how to measure that. There's the Healthy Places Index in California, and there's several elements that contribute to that. The economic factors, education, housing, healthcare access, the neighborhood, pollution, transportation, and other social indexes all contribute to a healthy index and Healthy Places Index. So the most advantaged can have a much higher number, and then the least advantaged have sort of a negative number in this Healthy Places Index. Next slide. So we wanted to show you as well some things that we're seeing as far as trends in the state when you look at it by HPI. So we actually have made a lot of progress in testing as far as the least advantaged persons having high rates of testing compared to the most advantaged as far as the HPI and who's getting the most testing. And as you all know as well, I think we have been monitoring this metric very closely as far as testing positivity and who is getting tested. And actually, it's been a requirement in order for communities to move forward in our reopening framework. Next slide. But unfortunately, with case rates, you can see a really dramatic disparity between persons in the low HPI or least advantaged compared to the most advantaged. So our cases are still, our disparities actually have increased with this big surge. And we have this high case rate compared to a lower case rate in the most advantaged versus the least advantaged. Next slide. And mortality also, again, you see this huge disparity. So those persons who live in a least advantaged HPI have a much higher mortality rate compared to those in the most advantaged HPI areas. Next slide. So actually go back and you can sort of, let's leave the last one up. So I think with an eye to all of this, really thinking about where and how can we have the most impact, but also respond to some of the feedback we have in, again, the setting of very little vaccine for a huge state like this, and how can we have consistency across the state. We've been hearing a lot about confusion, if certain places are moving more quickly than others, and how to operationalize even different occupations, and how do you prove that when you show up at a clinic, and how do we make sure we're not wasting the vaccine and getting it into arms before it expires, or and getting it out, especially when we're trying to parse out very small amounts into a large area. So we've been getting, again, all the feedback that others have mentioned, and we also brought this to the drafting guidelines work group yesterday to kind of get some more feedback, and really, in combination of thinking about the simplicity and consistency and frameworks, and looking again at who is most impacted in hospitalizations and death, really are thinking very seriously about focusing primarily on age and not as much on the sectors that we have been, collectively spending a lot of time together on. So I wanted to sort of pause there now, and I think, again, leave other comments to Dr. Aragon or Dr. Burke-Harris and really get a little bit more feedback from all of you. I think the drafting guidelines work group, despite a lot of the work that they have put into over time, these tiers and sectors kind of recognize some of the issues that they're also seeing on the ground in trying to administer vaccines, and supported this idea of considering how to shift even more on the age. We'd always put in these different tiers, age is one factor, but also had other sectors based on the other values we talked about as far as societal impact, equity, occupational exposure, and societal impact. But just really struggling with how we do this with scarce vaccine and keeping it simple and consistent.
Erica, this is Tomas. Can I add one comment?
Sure, please do.
Yeah, so one thing to realize is that when the hospital surge gets as big as it does, and the ICU capacities is so large that you go into surge, you end up canceling a lot of other hospital services. So it has an impact that goes way beyond the actual communities that are impacted as well. So it really affects the general society in general in California. Anyways, I just wanted to point that out.
Erica, this is Bobby and Tomas. There are a lot of questions in the chat about the volume of vaccines. Could you just go over that again very slowly? How many vaccines are we getting each week? When do we expect if ever, the ramp up of vaccines production to happen? When are the new vaccines going to come online that will help with the volume? You could just go over that again for everyone, so everyone's clear of the
Sure. Yeah, no, excellent points, and I can review that again. So as a start, we have had shipped to us about 4 million vaccines, 4 million doses in the state of California. And I showed you sort of, let me back into this and say that again, phase 1A, total population is about 3 million. And we are only getting anywhere from 300 to 500,000 doses per week. And I think, what are we in week 5 or so, week 4 or 5 of vaccine distribution? Our understanding currently is that we can at least have at that much, but may not get much more than that for at least the next several weeks. We are hopeful that there are a couple other vaccines that are, going to be applying for emergency use authorization. My latest understanding is probably the soonest that would happen is March. And I don't know, have not heard any really concrete information on how much, if and when those are approved, how much supply that will add. One of them is great. The Janssen one is only 1 dose, so that will really help a great deal as far as not having this complex issue around the doses. Although I should also mention that as well, because I know there's been a lot of confusion about that. So, as I think you all do know, both Pfizer and Moderna vaccines require 2 doses per person, either 21 or 28 days apart. We've actually had our scientific safety group look at this a couple times actually as well, as far as, do we feel like we can increase that interval, and does it make sense to try to get more first doses in and delay second doses? And really, they've been very clear that the science, and as you all know, and the reason we've appointed those members is because they are really experts in this field and have looked at the data about efficacy. And they feel really strongly that we should stick to, as best we can, to the recommended doses, because that has been shown to have that efficacy of close to 95% for those 2 vaccines. So the doses we get have been coming, and then there was, I know, a big declaration about whether or not there was this kind of a stockpile of second doses. And I think what we want to do collectively to try to minimize confusion amongst providers and ourselves, and even how we look at percent of doses administered is really a dose is a dose. And then individual providers, just like they do with other vaccines, like hepatitis vaccines that require 2 or 3 doses, need to manage their inventory, which is challenging given the small supply we're having. But we're really trying to keep vaccines moving both into arms and then into the providers that are giving vaccine. But you do have to keep in mind when we look at total numbers that are out there in the CDC tracker and in the media, they're talking about total doses, but a lot of half of those doses need to be second doses for people. So again, it's only less than 500,000 a week is our current allocation. It may increase slightly, but at the most, I think for the next several weeks, I think the most might be another 100,000 a week. It's a very small amount for at least for the next several weeks.
Erica, could you also add what percentage are now in people's arms rather than waiting to get into people's arms?
Well, I think that is the question we have all been very actively working on for the last, I'd say, how long, Tomas? Like 10 days of really intense work on that. And the data we have, I don't have it right. We do have our dashboard.
I have it in front of me.
Okay, great.
The latest that I saw was that 45% of doses are in people's arms. Now, some of those are first doses and second doses, right? But we do have, yes. So we're at the last as of yesterday, I think it was a little over 1.4 million.
I think we have hit the 1.5 million actually.
Oh, 1.5. Okay,
yeah,
fantastic.
Yeah. But we do still think that that's an underestimate. And we're working really hard on getting more data into the systems. But whenever we make calls to systems and providers and health departments, they have administered more, and we're really trying to get those data systems up to date.
Nadine, shall we go to questions?
Yes, and as we're going to questions, before we jump in, there are a couple of questions from the chat that I wanted to flag. Erica, one of the questions was around whether we have infection, hospitalization, and mortality data by disability. In terms of for our disabled community.
Yeah, no, excellent question. We definitely don't have it handy. And I will say a challenge again in our surveillance system is it's really the clinical data in there is not sort of an automatic feed for things like that from electronic health records. So it would need to be, and because of the diversity of the kinds of disabilities there are, I think it'll be a challenging data point to pull in the way our surveillance system is set up.
Thank you, Erica. And just as a flag, there was another question about whether we had data on sexual orientation and gender identity. And I will say, although that we know the state of California collects this data, the rate of reporting of this data is so low that we don't have valid reports to share with you.
Yeah, there's a huge amount of missing data, you're right. But we are starting to post that on our, believe it is on our website now.
Great. Bobby, do you want to walk through the facilitate the hands raised?
Yeah, I'd be happy to. So let's start with Andy, and then we'll go to Aaron, and then Charles, and then Melissa. And please remember to introduce yourself so that all the members of the public listening, and there are several thousand, know who you are.
Hi, it's Andy Imperato with Disability Rights California. I guess I just want to reflect back what I'm hearing, and Dr. Pond, maybe you can tell me if I heard it wrong. What I thought I heard you say, and Dr. Aragon also implied this, is that the state has decided to take an age-based approach to focus on, once you get through the 1A populations, to focus on people over 65, that at the current rate, it would take about 20 to 22 weeks to get through that population. And you're not likely to be getting to other populations if they're not already in 1A or over 65 until potentially May, if that time frame stays in place. Did I hear that correctly?
I think I would slightly repeat back that we are strongly considering this. I think we are here today too, and this is what we're struggling with, this really small amount of vaccine, trying to look at who is, again, who's filling our hospitals, who is the most, who's dying from this disease, and what can we prevent as soon as possible with this very small amount. Again, we do hope, maybe in March, April, May, that there's going to be more vaccine, but it's very unpredictable at this point. So trying to stick with what is at least what we think is predictable, it's been a challenge for us as well. I know that this is, the providers keep asking us as well, we need more vaccine, and, we need more vaccine. It's true. And we're certainly not holding anything back. We are really getting vaccine out to people as we can. But yeah, this is what we're struggling with, and this is what we're considering. Yes.
So if I can just do a quick follow-up, I think if you look at the people who are dying from COVID who are not over 65, and you look at what were their underlying health conditions, I think you're going to find that there are a lot of people with disabilities who are under 65 who are dying from COVID. The disability community can't produce that data for you. The healthcare community is the community that can produce that data. And from our perspective, if we wait until May to get to other populations, a lot of people with disabilities under 65 are going to die unnecessarily. And we feel like, to the extent that they have an added chance of dying from COVID, they're more like people over 65. So I know we've made all these arguments to you already, but I'm just going to say it again. We feel that people under 65 who are at greater risk of dying from COVID should not have to wait until May to get a vaccine.
Thank you, Andy, for that very passionate comment. Let's go on to Aaron.
Hello, Aaron Carruthers from the State Council on Developmental Disabilities. And I know that we've provided external information and resources about the impact of COVID on people with disabilities. And I do want to point out that the state has some good information of its own about how it's impacting Californians. And Surgeon General Burke Harris, thank you for posing my question out of the Q&A about really some good gratitude to the Department of Public Health team. Reached out to you early on in May. The team was responsive to say, we found a way to begin collecting disability information in our own surveillance. And it seems that collecting it that early on, you should have some really good information by now about how it's impacting people with disabilities. So I just want to make sure that's on your radar, that you have that as an internal resource. And I continue to be glad to be helpful to help interpret, because the way we're collecting disabilities in a broad way, and I've been able to come back and work with your team to help at least categorize your group. Additionally, Department of Developmental Services is collecting impact on regional center consumers. It's a different way to measure, a different way to look, but I think there's some really good information, starting with what you likely have in-house to take a look at what we're seeing externally. So really to echo and build on to Andy's comments. Thank you.
Yeah, thank you. Oh, one brief comment, and I do need to verify this, but in some of our data I've seen internally quoted, the risk is about 3 times the general population, or the comparison group. And I think I showed you some of the other elderly is 220 times or 90 times. But I do want to circle back to your point and make sure what is our most up-to-date information that we do have.
Thank you, Erica. We're going to go on to Melissa Stafford Jones, and then we'll go to Dr. Wasserman. And then I just want to give you the heads up who I have in line: Jose, Diana, Esther, Anthony, and then Orville. And then we'll see where we are. Melissa?
Thanks, Bobby. Melissa Stafford Jones with the First Five Association of California. One of the tenets of the work of First Fives with young children and their families is a holistic whole child family approach and a real systems approach. And I want to, my comments are sort of in that space, because the older people we're talking about are the grandparents and great grandparents of the children and families. that we care about, often who are also actually childcare providers for their families. So it is all connected, and we have an appreciation for that and of the complexity of how to operationalize all those connections in the reality of not enough vaccine. The question I wanted to ask was around whether the approach of incorporating the Healthy Places Index was specific to thinking about an age structure, or whether thinking about communities in the context of vulnerability is broader than an age-based structure. I think a lot of local First Fives have been working in close partnership with their local health departments over the last month or so, thinking about outreach to some of the most vulnerable workers that work with children and families, particularly childcare workers who are mostly Black and Brown women. And so I'm just wondering if there's still an opportunity to, from a systems approach, sort of think about the issue of age that you're bringing forward in the struggle around the prioritizations and keeping it simple, but also keeping front and center these issues around equity that we also know are so real in our communities.
Yeah, why don't I start, and then I'm sure Dr. Bracaris wants to add. I think there are two elements to this that are really important. There's allocation of the vaccine within whatever framework we have. And then there's also tracking sort of as a metric, and then also being able to use that metric and circle back to see where there's disparities in other interventions, and whether, if there's a disparity there, is it likely often a combination of access, outreach, and or hesitancy. And then I think, but really importantly, the allocation piece, I think, is what we do need to nail down, regardless of what framework we have. But I think thinking about how it goes within a framework or as a complement, and I do think we want to have ongoing conversations with this group about that too. Dr. Bracaris can talk about some more specifics with this as well.
Thank you, Dr. Pond. Yeah, that's absolutely right. And as I'm thinking about your comment and then also looking at the chat, I think that one of the things, so to specifically answer your question, the HPI is to look at a broader kind of social vulnerability, right? But I want to emphasize something here, right? So the point that we're getting to, and I see lots of comments in the chat around, our seniors are reaching out and feeling like they're having a hard time getting access to the vaccine. We're seeing, these challenges and those challenges. And I think that's the point of this conversation and this discussion with this body, right? Is that we absolutely want to look at a community vulnerability lens, but then how we operationalize that has to be really important, looking at those who are at highest risk of morbidity and mortality, right? And that's one of the things that we're considering, especially now as we are dealing with this significant surge, right? And so I'm going to talk more after the break in terms of how we might, looking at one proposal of how we might operationalize the Healthy Places Index. But to answer your question, when we look at vulnerability, what we're looking at is, for example, if we look by HPI, we would say, okay, if we are take for example, we have this priority of those 65 and older, right? Then it wouldn't be that we would apply HPI to then identify someone who is 35 but with a high vulnerability index, but rather we would look at how we can, as we're doing the 65+ how we can target and maybe leverage more resources for those who are 65 and older and also have a higher social vulnerability, right? Because it's going to take us, as we're seeing, 20 to 22 weeks just to get through that population, right? Before we even get to those who have, a lower risk of morbidity and mortality. Does that make sense?
Yeah, thank you. I mean, I guess maybe there's more possibility of conversation to just think about what is the balance for equity for other groups where there are no other options in addition to in-person work, while recognizing the vulnerabilities that you're describing in terms of morbidity and mortality for people 65 and over. I know it's just this impossible, really hard puzzle, but I think how
I want to emphasize that. Oh, sorry, go ahead.
No,
I want to think about that in the way that we're using the term equity, right, as we're talking about it, because one of the things that I think is really important is, and what we've heard from this group, is looking at the ways in which discrimination, marginalization, historic racism, all of these different pieces affect people's risk, right? And I think as we're thinking about that, if you have, for example, a group that is at 200 times risk of death, right? And then you're thinking about within that group, one of the things that I want is that we want to factor all of these factors, right? We want to factor in what is the risk of morbidity and mortality, how are the historic and contemporary discriminatory and oppressive factors influencing that risk. So we know that it shapes risk of morbidity and mortality, right? And we're seeing that even in the hospitalization and death rate by race and ethnicity. But if we look at the hospitalization and death rate by race and ethnicity, looking at the CDC data, right? What we see is that as a group, for example, African Americans are the risk of death is the 4.7 times the risk of hospitalization, 2.1 times the risk of death. When we look at those 65 to 70 years old, 5 times the risk of hospitalization, 90 times the risk of death, right? So again, it's that intersectionality that we want to pull together as we're thinking about, and as we think together as a group, right? As we, the CVAC, think together about, we want to raise these forwards, but how do we operationalize the concept of equity in the context of morbidity and mortality, right? Like how do we pull that together and prioritize that? And that's what we want to hear also from you.
Thank you. Let's move on to Dr. Wasserman.
First, I really want to thank Dr. Burke-Harris and Dr. Pan and such. You guys are doing, I think, the best job you can under these circumstances. I read through a lot of the comments, public comments, and they're heartbreaking. And at the same time, we don't have enough vaccine. And so I guess one comment I have is how we might improve the transparency of the fact that we don't have enough vaccine to help those out there who are freaking out, to help them understand. And maybe this group can help with that. So that's number one. And number two, I got to tell a story. My dad called me yesterday. I told my parents in March to stay home. My dad's 86. He's got multiple comorbidities. He belongs to a large health plan, and he followed the rules and he signed up for his vaccine, and they gave him a vaccine date of March 8th. And I said, Dad, you're 86, you've got these health problems, you need to contact your doctor. And he did, and he's now getting his vaccine within the next week. But it took him having a son who's a geriatrician who to tell him what he needed to do. And I think that begs the question of how we engage the health plans, the health systems who have the electronic records and have the information about the highest risk folks as we try to prioritize so that guys like my dad will actually get the vaccine before I do. I'm 61 and I'm really healthy, and I don't, I think that there's the balance there. And I think we all need to figure out how to help make that happen, with the caveat, until we have enough vaccines, we're going to continue to have a lot of challenges. So thank you for what you're doing. And I know you're doing the best you can.
Thank you, Dr. Wasserman.
Yeah, thank you.
Jose. Jose, introduce yourself. You're on mute.
Yeah, Bobby, thank you very much for allowing me to make a few comments. Well, just like Mike just mentioned, my name is Jose Padilla. I'm the executive director of an organization called California Rural Legal Assistance, CRLA. Large members of our community are farm workers, rural poor. One of the reasons why I joined this group was because of the concern of some of the matters just raised by Dr. Burke. This is personal to me because my father and my grandparents were all farm workers. That's why I became a lawyer for farm workers. So when I think about how we're thinking about pulling away from occupational approach to this thing, it's a little bothersome to me because I know that the farm worker community has a lot of both historic factors working against people speaking up for their interests, history of racism, the way Dr. Burke mentioned, and so here I started thinking about the HPI and that metric, and I said, you know what? If we were serious about A, talking about essential workers, and B, talking about that index, we would not necessarily be pushing age. We would be looking at the reality that farm worker communities are at a language, they have language barriers, trying to let them try to secure or communicate with the Department of Public Health in a lot of these communities. Some of these quarter of farm workers are indigenous. DPH doesn't have indigenous translators for a quarter of the farm workers that are out there. You're talking about poverty, you're talking about crowded housing, talking about crowded transportation. These folks go to work, 30 to a pickup, 30 to a van. The educational level, 3 to 5 years from Mexico. So to me, and they have no insurance, they're immigrants. And so to me, I question us no longer valuing occupational, the occupation as a metric or as a factor when we look at essential workers. And so I am hesitating about continuing to go with age when I look at that community that suffers for all of these metrics. When you look at metrics of poverty and the way that they suffer, it just hurts for me to think that because of age, more deaths, there will be a higher mortality. And as a matter of fact, I don't even think we keep data on farm workers. And so I think that is, I can't accept the fact that we're going to continue to forget the need of that community who is especially vulnerable. And I'm going to stop there. I think I talked too much.
Well, I'm gonna ask you one more question. I know we have a million questions, but I want to ask this question because I think it's really important. And I think that it's not about forgetting about the needs of farm workers. It's far from it. That's why we're having this conversation, and that's why we brought this back to you, right? So I want to ask you, how would you solve that? What would be your proposal? Would you propose that we prioritize farm workers over individuals 65 and older who have a dramatically higher risk of morbidity and mortality? I mean, that's the question. Is that what you would put on the table? Because I want to,
no,
and if not, what solution would you? Because it's heartbreaking. It's heartrending for all of us every day. And the challenge that we have is that we don't have enough vaccine, right? So for every occupational group that we move to now, right? That means that there's going to be more 65-year-olds and older that die, right? If for every 65-year-old, right, that we prioritize now, there's going to be a lower number, but still there is going to be trade-offs of people who get sick and die, and it's a matter of how many it is and what right, because we're in between a rock and a hard place. And so that's one of the things that we want to ask you is what would be your recommendation?
At this point in time, I really was very attentive to your articulation of equity, and I keep that issue of equity right in front of me. we're into our 6th meeting. And a lot of us who work in rural California are trying to figure out how we're going to be doing outreach to the farm worker community now that all of a sudden they're there. We need to reach them because they're fearful. They know what's around them. Their employers weren't giving them masks. I mean, and so to me, I think that up until now, I have no problem with the age decision that we made at the last meeting. 65 plus, I thought that was the right way to go. And I remember why we were doing it for a lot of the same reasons we're hearing now. But now what doesn't feel good to me is that now we're going down, we're going away from the occupational, which to me was an equity issue because of the fact that as an essential worker, the farm worker is especially at risk because of the conditions under which they work. And so to that extent, that's why I thought, okay, the phase 1A, phase 1B, okay, now there we are, we're getting to farm workers because implicit in our discussion about equity, everybody recognized that was an essential workforce who that worked under really difficult conditions. And in that balancing act, I felt very comfortable with where they're going to be now. And now it doesn't feel as comfortable when we're putting age once again in front of that farm worker getting that vaccine in the phase 1B or whatever that was that we had decided. That's what's feeling really, it's almost feeling political that some folk or the politics of this are pushing themselves ahead of farm workers. And that's what I'm talking about that feels uncomfortable.
Okay, so it sounds like you were okay with the 65 plus going at the same time.
Yes.
But okay, so that's helpful. And I think that's helpful. And let's talk about what the implications of that are. But why don't we move on, Bobby? Who was the next person in the queue?
Yeah, thank you, Jose, for being so articulate about these issues. Diana?
Yes, thank you so much, Diana Telupson Torres with the United Farm Workers Foundation. I'd like to say that I very much agree with Jose Padilla's comments. Today's conversation about potentially moving exclusively to age-based system is definitely disconcerting. I found out this morning that one of the United Farm Workers members, who's been an amazing leader and worked in agriculture for decades now, just lost his life last night to COVID at the age of 64. And so, many colleagues and previous meetings have emphasized that not all individuals who are 65 and over have the same level of vulnerability. And like Jose, we were also comfortable with farm workers and 65 plus individuals being in the same category. It makes sense. But we really can't ignore the fact, we saw in our survey of over 14,000 agricultural workers that 78% were not insured. It is a real reality that the level of vulnerability is incredibly high. And so you asked Dr. Harrisburg that, what are some of the solutions? We really have to have a specific strategy, a potential task force that's targeting farm workers, that is coordinated by the state, working alongside the unions that represent farm workers, CBOs, and individuals within the farm worker community, so that we can reach this very vulnerable population that has huge disparities. We cannot ignore that. In earlier meetings, we saw the data that CDPH presented that showed in every level of vulnerability, farm workers are almost exclusively Latinos. They are almost exclusively immigrant. And so we really need to emphasize the fact that, as essential workers, they are amongst the most vulnerable of essential workers. I think immediate resource allocation to be able to reach out to this population is going to be very important. And the structures and procedures that are set in place to work with the farm worker population so that they can have access, because many have so many issues just with the processes that involve signing up through a website. There are so many things that we can do together to be creative so that we don't ignore the fact that we have individuals who truly are I think are waiting to hear from us so that they can get their vaccination. I'm in the same place as Jose and would love to hear your comments, Dr. Burke-Harris, about keeping those individuals within that category.
I think that my question that I want to understand how people are thinking about this question is, I truly want to understand that we recognize that when we talk about keeping more sectors, right, in that tier 1 of phase 1B, right, that moves that 22 weeks to, a much different number, right? And so and what the implications of that are. And so that's just what I want to understand, is how folks are thinking about that.
Thank you, Diana. Let's go on to Esther, and then after Esther is Anthony.
Hello, everyone. My name is Esther Bejarano. I'm a community health worker in Imperial County, 2 hours east of San Diego. I think here I really want to mention we cannot derail, and I, again, agree with Diana and Mr. Padilla. We're talking about essential workers. We're talking about people that cannot afford to stay home. My mother lives in San Diego. She's 65 years old. She lives on a hilltop. She orders everything from Costco. She can wait for her vaccine. My father works in the fields. He's 70 years old. He works from 12, he wakes up at midnight and goes back home till 6 in the afternoon. There is no hand washing stations. There are no masks. There is $50 a day pay. They are working to feed us today. My mother can wear a mask. She just ordered N95s. We cannot compare a 65 and up that lives in La Jolla to a 65 that lives in Imperial County, where we are completely overburdened historically from air quality. Our lungs are not growing the same. And so we are dying on a daily basis. We cannot compare 65-year-old here to La Jolla or to a beachfront. That is what we have to see here today and decide. It's going to be 5, 6, 7, 8 months for someone who has to work, who travels in a car with someone that is infected, who is going and uses one restroom because they have a break 1 hour. And guess what? Everybody have a break and there's no hand washing station. My brother works at Costco. He takes care of himself, but he has masks. He had hand sanitizer. He is given everything. So 65 and older, education is key. Why are we having 65-year older, and why do we have this large rate of people dying? Are they dropping their guard? Can they stay home? Yes, they are not essential workers. If they can wait, let's make sure that our essential workers, those that are out there right now, get the vaccine. What are the communities that the highest have, the deaths? 65 and older, like Imperial County, like Fresno, like the Central Valley. Why don't we look at the counties with 65 and older dying, right? And what are the counties that are not, that can wait? That is where I would want to shift myself to. Again, we cannot, we're looking at all the data you're sharing here. All of the data is pointing to the farm workers. They're the most vulnerable communities, the most affected people. I just spoke to a farm worker last week. The father, the 2 brothers died, right? And they worked 15 hours a day and they died. And so I'll stop there. We want it to be equitable, but you cannot compare vulnerability just solely based on age. Since the vaccine is gold right now, we don't have enough. So we've got to make sure that every single one is on that person that really needs it. And I'll stop there.
Thank you.
Esther, very much.
Yeah, thank you so much. I just want to briefly respond and probe a bit too, and just want to share the sentiment that, absolutely, this is so hard for all of us. And, and you pointed out that, that you have a relative that is a 70-year-old essential worker. And I do think very much, as I just mentioned, there are over 6 million people over 65 within that. I think, the goal and approach, and again, want to continue to work with you. And, my understanding is there is going to be a task force, and we want to start this outreach now to get everything set up when we have more vaccine. But even within that, and to your point, that the priorities then are, HPI and or, and even what we have posted now based on the discussion from last week are that older age, again, has just the highest, but also occupational exposure, so that we do want to make sure we're prioritizing, to your point again, essential workers over 65, over 65 who are not, and or, I think looking at HPI. So I think within, again, we have these really tough, very small amount of vaccine for over 6 million people. And I want to agree with you and have ways that we operationalize all across the board how to prioritize within that group for the highest and most vulnerable, which are, I think occupational exposure and HPI as two other key things.
Thanks, Erica, for adding that. Anthony, we'll go to you next, and then Orville after that.
Anthony Wright from Health Access California. These are tough trade-offs. I have some clarifying questions that I hope will add to the discussion. So just, number one is just, I think I did find compelling the age-based because of just, for health access, all of our access to the healthcare system is dependent on reducing hospitalization and mortality. And so that is such a important and compelling. And I do think simplicity, equity is actually, some people have tried to cast equity against speed. And I think simplicity, equity is aided by simplicity. Equity and complexity can be a barrier to equity if we don't do this right. But my question is that, in terms of, for clarity's sake, my understanding is that we actually in the governor's announcements moved to 1B tier 1, which includes not just the age-based, but some of the essential worker categories. But then that would be at the discretion of the various entities, with a prioritization and age, but that they could go to, food as well as emergency and other workers. So please clarify, because that's my understanding of reading the website, although looking at the governor's statements, it hasn't been entirely clear. So I want to, or other statements as well. I would say, so one question is just where are we on exactly those permissions? And I do appreciate that one of the reasons it's confusing is because we're not doing one implementation or even 58, but if we're doing it through providers as well, we're literally have hundreds of implementations in the state of California. And so I think it would be really helpful for us to get data about like how of the 3 million that we even have now, how much is going through counties, how much is going through hospitals and health systems, how many is going through pharmacies, so we can have like some granularity about this. And then my other question is just, do you have the data to actually know who is within those categories, who is getting 75% of their vaccine out there versus who's at lower levels? Because I think that this is a really, like, I don't think I think a 45% mean doesn't tell us anything about what's going on the ground, county by county and provider by provider. And so that's my final just piece is that I do think that I also think that some providers may be treating this differently. If a provider would treat this really differently if they have to save they have to save a second dose because they're not sure if another shipment's coming tomorrow, versus if they feel like there's about to be a ramp up and they should be building infrastructure as we go along. And I want to make sure that we're clear about what's happening with regard to that. At the end of the day, I think that equity is as much about the logistics within these categories of technology and transportation and other barriers as it is with these prioritization categories. So I'd love to have further discussion about that. But those are some specific questions if you have any answers to them.
Sure, I can take those. Thank you. Those are all excellent questions. I think I think I want to acknowledge your first very important one, which is where are we now? And you are right on actually, which but and to also your point, like you actually understand that we have said we were moving to 1B and that we are prioritizing over 65 and up, but there has been this flexibility. You are absolutely right. And I know there are some, jurisdictions and places that have, some things set up now for teachers, for farm workers. And we're getting this feedback about simplicity and confusion and to go to your other questions, we do have on that website now a breakdown of how much is going to the multi-county entities and how much is going to local health departments who then allocate it though to other providers. So that breakdown isn't on our public website at this moment, but we have been working on those very same questions and issues and trying to understand that as well. So who is getting more who's able to get more out? And back to equity, really understanding that, we want to continue to get the vaccine out because again, we're all going to benefit more from overall community, but also as we can all imagine, those who are getting it all out also are more resourced and are not necessarily serving the people that are the most under-resourced or for example, in the lowest HPI. So struggling with that as well. But that's been a huge priority, as Dr. Edegol mentioned, as far as data. So really trying to strengthen our data systems as far as how much we know is going where. We have this data from what's shipped, and then we're really trying to better tally what's received. Yeah, how much is first dose, second dose, how much do you have in hand, how much have you had to waste for any particular reason, and then what percent are each individual providers getting out, and how do we, in this very decentralized system, have a handle on that versus we're also looking at other ways to better not only gather that data, but figure out how to have some accountability to your very questions. So all excellent questions, and we will keep you updated, but also part of again, to be really frank with you and the public, this is what we're looking at as we speak and trying to really improve.
And I want to just add to that piece that, part of the reason we're coming back to have this conversation is that we hear from the public that the system currently as it is feels confusing and is moving more slowly. We're also hearing from our local health officers that the more complications, like as complexity, is a barrier to the speed at which we are getting the vaccine out, right? And so there is an extent to which, talking about, the notion of intersectionality, right? We really want to understand that if we, simplifying saves lives, right? The simpler it is, the easier it is to implement, the less confusion it is, the less people are wandering around or wondering what they have to do, then the better that we can do this process. And so as we're thinking about how we simplify our systems, right? This is what the purpose of this conversation is to hear from you all, your inputs about, really to do the thing that this committee was set up to do, right? Which is receive public input for consideration as we move towards making these decisions.
Okay, let's move on to Orville and then we'll go to G. And I know a number of you have your hands up and I've got you recorded. We'll see how much we can get through before it's time for us to move on to our next topic. Orville?
Yeah, thank you, Bobby, and thank you, Dr. Burke-Harris and Dr. Pond. Orville Thomas, California Immigrant Policy Center. First, I really want to amplify what Deanna and Hosea said, regarding our immigrant essential workers, especially those in farm and ag and food. A lot of this is happening not because they are part of counties that have neglected public health warnings, it's because they can't be in positions to avoid going to work, or their corporations or businesses have not given them the personal protective equipment needed for them to stay safe. We understand that there is obviously a lack of quantity in the vaccines, and wanted to make sure that these essential workers continue to remain in 1B. And also on top of this, start the amplification process and the community education process very early. And I know it's going to be later on in this meeting, so I'm really excited to hear about this. These are also populations that haven't had some political strongholds. So we've seen some efforts to get them protected with Cal OSHA for in-home workers, or for, large farm and ag employers to give them their workers' bill of rights on location at the workforce. And that has not been, included last year. And these are also populations that aren't included in any federal stimulus or any state economic packages. So they don't have the luxury of being able to stay home. They are multi-generational households. They have large community development. They don't have access to health insurance. They are often traveling throughout the state based on the season and the agricultural crop that's in demand. And we want to make sure that all of these are taken into account. And, I think that what you're hearing is the surprise in a lot of advocates' voices that this is starting to be considered, given that, we've had this equity conversation in place for farm workers. And we've realized with the administration that the food and ag essential workforce is very much at risk when it comes to, pervasive practices that put them in much greater danger than those that could avoid it, and being able to stay at home safely in place. So thank you. I realize it's a very tough topic to be discussing right now, but I'm hoping that when we get into these conversations, the spirit of all these advocates can essentially help us plan an equitable way forward.
Thank you, Orville. Let's go on to G and then Deborah.
Hi, I'm G. Perdigones. I'm representing SEIU Local 1000, 96,000 state workers across the whole state of California. I was under the impression that we're not moving out of the essential worker criteria and then add the 65-year-old criteria. And that's simple. I understand the age criteria because I'm an MPH, Masters of Public Health student, but I also understand the equity side of that criteria. I want to prioritize essential workers. We were deemed essential since almost 1 year now. And if we could not get our essential workers protected first, then, and our vulnerable communities first, then we're not gonna have that equity factor in this criteria. That's my opinion, and I hope you would consider it, Dr. Burke Harris, and Dr. Pan, and I hope the committee will consider this. We don't need to move out of the essential worker criteria. We just need to pivot it a little bit to consider the age, add age to it.
Thank you, G. Let's go on to Deborah and then Jody.
So Deborah Shade, representing the California School Board Association. Just a couple of comments. I understand the need for age-based. I think it's really simplistic. However, the slide and the information that you presented did not show those that have underlying conditions. And I think our group had agreed that underlying conditions for somebody 65 and older really trumps them and puts them in that higher risk category. I'm here to speak for all the students that are not receiving education, that are living in a child abusive situation, and no teacher is reporting because they are not in a classroom. I want to talk about the 10-year-old that committed suicide in San Diego recently because of the trauma of disconnection, isolation. And I want to talk about the future of California. We have got to get our kids back to school. And you will not find very many unions that are ready to cross that line without a vaccine in development, because districts cannot afford the type of COVID-19 testing that you would have to put in place to open doors and keep school open. So again, I'm a public health background as well. I understand the urgency for ICU, healthcare for all. But I do believe that there's a disaggregation of that data that we have not seen that shows underlying conditions. When you look at daily death rates, most, if not the majority, had an underlying condition. And we approved that, we talked about that, we were supporting that, but removing essential workers that are at the front line and prioritizing a 65-year-old like I played tennis with yesterday who got his COVID-19 test and he's fine. That's where I think, I'm not sure how the simplicity and those broad strokes are really servicing California and moving us out of this COVID-19 pandemic. So I really, again, I thank you for the work. I think you guys have very difficult decisions, but you needed to hear from the California students that are not in class, that there is a big risk there for the future of our state.
Thanks, Deborah. Jody?
Thank you. Jody Hicks, representing Planned Parenthood Affiliates of California. And I just want to say, I appreciate this conversation is difficult. I appreciate looking at the HPI index to try and get at communities. I appreciate, Dr. Burke, that it was even brought up what systemic racism has done and how it affects all of the communities and how we're looking at this through an equity lens. And I feel like I'm a little bit of a broken record on this piece, which is the second part of it, though, is if we don't acknowledge that the structure of our public health system is not in a way that can equitably give care to our communities, then however we prioritize this list, it ends up with people not getting those vaccines in an equitable way. And I think if we learn, and I think you're correct in what you're hearing back, it is confusing, it is cumbersome, it is slowing things down, but I think we can also learn that, you know, I was really happy that my elderly parents were able to navigate and get the vaccine, but honestly, it was those people that were able to stay on the phone for very long hours and were able to have kids that can help them navigate through that system. And so when we start getting down into other tiers like farm workers and like those very much more vulnerable communities and individuals, my concern is they will not have the time and resources to be able to navigate. And the big systems are a good starting place because we do need wide swaths of lots of people getting vaccinated all at once. But it is when you get outside of those big systems is where you have the vulnerable communities, and the providers that traditionally treat those, quite frankly, like health centers like ours, are also traditionally under-resourced. And so, you know, to let you know what I'm hearing on the ground from our health centers and our providers is they are willing to send out volunteers. They're willing to do as many vaccines as they can to treat those communities, but they do need resources because it does also then it's disrupting the care that they have to also be giving at the same time. And so we have to also decide that we're not just prioritizing the criteria of who gets it, but that we're investing in how people are getting those. And I did hear Dr. Aragon, and I appreciate saying that he wanted to secure, and we want to ensure that those community health centers and the community-based folks are more secure. But, you know, I don't know what that means in terms of operationalizing that. Is it the counties? How are we doing that? And I think if we decide, and I think the other part is, does the HPI, if you overlay it, and I don't know the data, will that also capture maybe broad swaths of farm workers and essential workers? And if it does, then let's move into that. But we have to prioritize how we do that and how we reach them. So that's all I'll say. I think the fear is we keep moving down into that, and people are still not getting the vaccine because we haven't tackled that second piece of it. Thank you.
Thanks, Jody. Nadine, I think we are out of time for this section of the agenda. We do have a number of people still in the queue, and perhaps their comments will be relevant in the next two parts of the agenda.
Thank you so much, Bobby. Do you mind just taking a moment to summarize our public comments, and we can marinate with those public comments and along with what we've heard so far in our discussion this afternoon as we go for a brief break.
I'd be happy to, thank you. I just wanted to remind the members of the committee that starting with this meeting, I've sent out a brief summary of the public comment in addition to the actual public comments, as was requested in the evaluation that you all completed. We received 286 pages of public comments, 645 individuals or organizations made submissions in the period since January 5th, the day before our last official meeting, through Monday, when we had to close the public comment in order to compile it and send it out. We had many questions from healthcare workers about where and when they can get vaccinated. And we had 58 comments from people asking us to simplify the system of how to get a vaccine and how to find out where to go to get a vaccine. We had almost 500 comments from people asking to prioritize their occupation in the first tier of 1B. And that included letters from the Tulare County Board of Supervisors, the Santa Cruz Board of Supervisors, all the major news outlets, the Supreme Court Justice of the Court of California, from the LA County Board of Supervisors, Chair Hilda Solis, and from many, many, many others, including 347 veterinarians. We had a number of people who wrote in wanting to offer their help in providing vaccines. We had someone who wrote in questioning the need for vaccines and asking about vaccine safety. We had a number of people who wrote in asking why people needed second doses of vaccine, and another set of people asking that everyone get their second vaccine. We had questions about the federal long-term care partnership that was spoken about earlier. And we had a thoughtful, a long letter from the California Labor Foundation encouraging the extension of the supplemental sick leave for COVID-19, asking for more consistency across the county distribution system, workers who are administering vaccines, and asking that the vaccinating organizations do not require employer certification, because this could act as a barrier to many essential workers getting their vaccine. I'm sure you've all read the extensive comments, and as was mentioned earlier, they are passionate and heart-rendering and require our attention. Thank you.
Thank you so much for that summary, Bobby. And now we will take a brief break. It'll be 7 minutes, and we will come back at 4:35 to start our next session to talk about practical methods for operationalizing equity. So as a reminder, folks, please go ahead and mute your lines and turn off your cameras, and we will see you at 4:35. Thank you. All right. So it looks like we are at 4:30 or 4:36 now. So we are ready to reconvene. And we want to move into a conversation about different strategies to use a practical and effective equity focus for vaccine allocation and distribution. And so really thinking about, so I want to start by first again saying thank you to this committee for your passionate, while still remaining very respectful, so I appreciate that, engagement and advocacy. I really, it's very, very much appreciated. And as we're having this conversation about thinking about how do we respond to the need for simplicity, and the recognition of scarcity, while at the same time addressing some of the important issues and holding the values that we hold for engaging in this effort. And so we heard at the last meeting, right? And we've been talking in this meeting about equity and how do we ensure that we are maintaining a strong focus on equity. And we engaged with, our teams worked with health economists and look at different strategies for operationalizing equity. And if we could move forward to the next slide, please. One of the potential mechanisms that we're looking at, and we'd love to hear your feedback on this, is a categorized priority system. And a categorized priority system is a data-based tool to calculate how to distribute scarce resource equitably. And it supports a need for both simplicity and equity. And the way that a categorized priority system works is that it takes a certain percentage of vaccine and allocates it specifically according to a metric or an indicator. And then the rest of the vaccine is allocated as it would otherwise be. So for example, I will go in retrospect because I think that's easier. If we were to look at applying a categorized priority system for phase 1A, for example, and we were looking at healthcare workers, for example, right? We would look at, and we were to use a system where we would say, we're doing a 20% categorized priority system. So 80% of the vaccine supply, when it comes in, we get 100% of vaccine, so we get 100 doses. 80% of those doses would be allocated to the counties based on their numbers of healthcare workers, just as they would have been otherwise. And then 20% of the vaccine would be, we would apply a lens of looking at in this case, we use the example of the Healthy Places Index, HPI, looking at the lowest quartile HPI, and we would take that 20% and then allocate it to the counties, prioritizing those with the lowest quartile HPI. Next slide, please. And so an example of how that would look is that, again, as I said, if you have 100% of vaccine doses, 80% allocated according to, whatever methodology we ultimately end up on, right? And then 20%, if that's the case, allocated based on this HPI index. And so what that means is that, and that number could be 20%, it could be 10%, it could be 15%, it could be 5%, it could be 25%. So that is a number that needs to be selected. There's no fixed number. But if we're assuming in this model 20%, right, then those doses would be additional doses that would be prioritized to go to the communities with the greatest risk as assessed by HPI. Next slide, please. And if the categorized priority system results in increased amount of vaccine for a county that's facing operational challenges, one of the things that we're really looking at, because we heard it earlier in the conversation today, we've been hearing it, is the recognition that some communities, capacity is an issue, right? And operational support is an issue. And so really looking at whether the state could also allocate additional operational support. And then as we're thinking about an emphasis of folks 65 and older, right? The question of whether allocating additional doses using a categorized priority system to our most vulnerable communities would be a way to address some of the concerns around equity. And in addition, the state would could provide guidelines to local health officers that the additional vaccine allocated based on HPI be targeted to individuals living in the lowest HPI quartile zip code. So for example, if we were looking at 65 plus, we would say, you know what, you can allocate this to the individuals who are 65 plus, but who are living in the lowest quartile zip codes. Next slide, please. And I gave the example of the Healthy Places Index. And the reason I gave that example is because our teams looked at several different metrics that could be used. The SVI, Social Vulnerability Index, HPI, the Healthy Places Index, and there's also a Sergo COVID Vulnerability Index. COVID Community Vulnerability Index, which uses a slightly different set of metrics. And the recommendation from our teams was that HPI be used for several reasons. One is that HPI is already in use for other policy and equity tools, including our Blueprint for a Safer Economy, our Health Equity Playbook for communities, and the forthcoming vaccine coverage equity metric. And for that reason, and again, when we keep in mind that simplicity saves lives, when we think about how we recognize that many of our local health jurisdictions are dealing with a tremendous amount of challenges and operational issues, using a metric that's already in existence, we believe would be helpful in facilitating ease of implementation and rapid implementation. The HPI also has zip code level data, and our vaccines are currently being allocated by zip code. And while HPI doesn't include race and ethnicity data or disability information explicitly, what we asked our epidemiologists to do was run the numbers and see what is the difference when we use, for example, the Sergo data versus the SVI versus the Healthy Places Index. And what we see is that by and large, these metrics tend to identify the same communities. And so for that reason, it's felt like there's not a lot that is missed by using the HPI, because when you put it into practice, what we see is that they're identifying much of the same communities. Next slide, please. And so when we're thinking as a state about how we're operationalizing equity, we wanted to share with you a couple of just the key tools, because we see this as part of the overall package that the state is using to operationalize equity. So a part of that is engagement and outreach, and you'll hear a little bit more about that after this section. That includes media, paid and earned media, multiple languages, CBO engagement, utilizing that census infrastructure. When we think about vaccine allocation, right, we recognize that our sector-based strategy was one way of operationalizing equity. We recognize that if we're thinking about you know, whether or not we're going to stay with that sector-based system, a categorized priority system based on HPI is another way to operationalize equity as well. And I say that not to say that it has to be one or the other, but I want to highlight that it's a way to hold a focus on equity, which we felt was very, very important. We have the vaccine coverage equity metric that you learned a little bit about at the not our last emergency meeting, but the meeting prior, our last scheduled meeting, and which is still in development, and our local support. So supporting counties with the COVID-19 health equity playbook, and then also resources to reach vulnerable communities. And that is done in partnership with philanthropy. So I'm going to go ahead and pause there and open it up for questions and discussions. Would love to hear what folks are thinking.
Okay, I want to make sure that the people that had their hands up from before have a focused comment on this topic. So Moises, why don't we go to you, and then we'll go to Carol Green, and then to Karen, and then we'll see who else is up. Looks like Lisa Hershey also.
Thank you. Moises Varón from California Alliance for Child and Family Services. I'll try to pivot my comment to what was just presented. I think that one of the challenges that we've been experiencing, we represent 150 organizations throughout the state that provide a range of therapeutic and mental health services to youth, especially very vulnerable youth and families. And what we're seeing is that as we continue to have these evolving methodologies and the lack of consistency, that it creates expectations that may lead sometimes to frustration. So it seems that something that it's important, starting with the fact that when it comes to allocation of what we have available today of vaccines, needs to be clearly communicated. And I believe that Dr. Wasserman talks about that. That is absolutely key, because I think we wouldn't be having these conversations about when and how and who if that was not the issue. But it seems to me that whatever methodologies identify, and it keeps changing, it has to be communicated in a way that is very clear, but also it's anchored in what we have available in terms of capacity, in terms of number of vaccinations, and also create clear expectations about what will be the timelines and length of time that may take to be able to implement these things. Because what we're seeing in the field now is that some of our workforce that is considered 1A is trying to get appointments and is not able to have access. And then we hear that another group is being added, a large group, understandably so, based on age. And now as a result of that, we have bottlenecks that are being created for both groups. So I think that that's creating a great deal of frustration and expectations when we're also trying to help our workforce understand the value of vaccination. So I am concerned as we move forward that we need to really learn from what some of the challenges that we've experienced now, which are very understandable, and use that lens to be able to identify how to develop these strategies moving forward, but also how to communicate it in a way that is clear, that is transparent, and create clear expectations.
Thank you, Moises. Let's go on to Carol Green.
I'm going to try to move forward with what you suggested. Operationally, I think one of the things we might think about is doing some workplace vaccinations for some of our essential workers, particularly our more vulnerable groups. One of the things that strikes me, and I am not a public health, I'm a public health advocate, but don't work in public health, is when we're talking about these communities, we still have the challenge of people with greater means having the ability to travel. And I'll just, not to tell too many stories, but I spent yesterday making sure my parents had appointments for their vaccinations. They're both in their 80s and they need them. But I asked my dad, I'm like, can you drive 65 miles? Because that's where the place is that I can get you the appointment. And he could. So that's a difference between people that can drive and people that have a car and money for gas. And I'm not saying my parents are wealthy, but I'm just saying as an example, while I was going through this process, I was thinking about our commitment to equity and was thinking that even though my parents are older and definitely fit into this category, they're in a privileged group of people. And as we talk about our essential workers, making sure that those that are most vulnerable are still have access, because we might all think that navigating computers, and let me tell you, I felt like I won the lottery because it was quite a challenging experience. Happy to share more details with that about you later, but making sure that our essential workers that are most vulnerable and our populations that are most vulnerable are still getting access to this vaccine still needs to be a priority. And I understand simplicity, and I understand that age ranges that we're talking about and the need for that to free up those ICU beds. I completely understand that. But if we just set everybody over a certain age, that would be faster, but it wouldn't be equitable. And I think it wouldn't meet the difficult discussions we've been having throughout these past several months. So I just want to share that. Possibly workplace vaccinations, if you go out to where the farm workers are and get them vaccinated, if you go to the schools where the educators are and get them vaccinated, that might also be a simple way to do things.
Thank you, Carol. Let's go on to Karen and then we'll go to Lisa.
Sure, thanks, Bobby. And I, want to appreciate the work of Dr. Burke-Harris and everyone on this and on bringing a place-based approach into this. And it's something we've been asking for broadly. So I'm glad to see the consideration and also the acknowledgement that if we're not careful, we might end up sacrificing equity for speed. And we don't want to do that in California. So I just want to, say that I appreciate that. I do think there's some considerations. One is, it really matters what the EM is. And so without having that defined, I think it's a little hard to have this conversation about what the prioritization should look like when we don't really know how well the 80% EM will account for equity. So I just want to say that at the outset. I also think generally, as I'm understanding this proposal, that I would say, 20% of the vaccine allocation going to the equity strategy in my mind isn't sufficient, isn't really equity, sort of saying, okay, 1 in 5 vaccines will be distributed equitably. And I'm not saying that's what anyone's saying, but I am a little worried. I'm not sure if that's just a model or if that's what we're trying to settle on is an 80-20. And if we are trying to settle on an 80-20, I'd be concerned about the 20 being very low. I also think the formula is a little bit unclear to me, and I think it's going to be really important then when we identify the HPI-based locations that we look across the entire state and not just county by county, because we have counties that have far more zip codes that should be targeted that are severely disadvantaged in some counties than in others. And I do think we need to look, really make sure that counties are not only getting their allocation based on that, but actually distributing the doses in those neighborhoods. Just 2 more things. One is on HPI. I do support the use of HPI. I think it's important. I also think we might need to supplement it for some populations. And so without being overly complicated, I think it would be good if there were a way for counties to propose additional communities that they think they need to focus on for different reasons to the state, such as our small Pacific Islander communities that might not be captured by HPI or people with disabilities. If there were a way for counties to say, we have these quartiles we want to focus on, we also have this community over here that we want to focus on and get state approval, something to supplement the HPI, I think would be important. And then finally, just that I really, I appreciate this slide about operationalizing equity, because the implementation in my mind actually matters more than the prioritization and how people are going to get it. And I'm still wondering how we get to really having community-based sites for the distribution once we've identified where we need the allocation to go. I'm still not seeing that, and I'm really concerned about thinking even if the doses are allocated for these communities that they're going to show up at Cal Expo, I think is not realistic. And so really want to make sure we have the implementation there and recognize that outreach is not going to be sufficient. And then finally, I would hate for us to be turning people away in these severely disadvantaged communities because they don't meet the priorities, because we already have a huge amount of hesitancy to overcome. So if someone shows up with their family in one of these zip codes, I really would encourage us to give health departments the flexibility to vaccinate everyone, because turning people away who already face hesitancy, I think is just going to add barriers over the long term that we shouldn't have. I'll stop. Thank you.
Thank you, Kieran. That was Kieran Savage-Sanguin from CPEN. If everybody could introduce themselves as they start talking, that would be great. Lisa Hershey. And then we'll go to Ronnie, Christina, and Amanda.
Thanks, Bobby. Lisa Hershey with Housing California, advancing policy on housing affordability and homelessness. I'm going to plus one what Kieran just said, because she made a lot of the points that I was going to make. And so I'll just acknowledge two other points and ask one clarifying question. First of all, I really want to appreciate all the work that Dr. Burke-Harris, Dr. Pon, and CDPH and everyone else has done, because you're truly building the plane while you're flying it and having to adapt to what you're learning from a population-based perspective. And I understand why you're leaning into where we're seeing morbidity and death. At the same time, from my public health background, I really want to go upstream and look at it from a prevention perspective and really lean into equity. And my second point being, I am so appreciative of the operationalizing equity. And as Kieran just stated, I think that is the key and the core part. I would love to dig deeper into the categorized priority system and understanding the allocation of vaccine based on HPI, which I fully support. But again, I don't fully understand the 80-20 and want to re-examine that. And then thirdly, I just wanted to note, that's really my question, I think, is about having a deeper dive into that and fully understanding it, because I greatly appreciate the opportunity to weigh in. Oh, I know what my third point was. My third point was I just wanted to share on a positive note that some of our affordable housing developers who have big communities of people that are low income, primarily Black and Brown and seniors, are already distributing the vaccine. And so we are seeing a deep lean into equity in a really positive place-based way. Thank you.
Nadine, any comments back to Lisa's questions about the equity formula, I guess you'd say?
Yeah, thank you so much. And so in terms of the question in terms of what does the 80-20 mean, right? I'll see if I can think about explaining it in a different way. But the idea, so the notion there is that right now, 100% of our vaccine is going out simply based on our, phase system where we are, phase 1A, phase 1B, et cetera. And the notion is that, so that would continue to happen, but as we are allocating based on our phased system, that we would, the 20% of vaccine would be targeted to provide, to enrich the communities that have the lowest, that are documented to be at greater risk, as we saw from the data around vulnerability and what that means in terms of increased risk of hospitalization and death, right? So this would be a way to operationalize getting additional doses to those communities. And so essentially what that means is that it would be a way to allocate slightly greater doses of vaccine to the communities where the data is telling us that there is greater risk of hospitalization and death. So that would be the it'd be kind of an overlaying of both of those things.
Great, thank you. Let's move on to Ronnie and then Christina.
Hi, thank you. Ronnie Kelly, County Behavioral Health Directors Association. I really agree with what Moises was saying about communication, and thank you, Dr. Burke-Harris, for pointing us towards operationalizing. Because as we all know, this is very difficult to do with the current infrastructure we have with CDPH and a lot of the changes and each individual county and jurisdiction's Department of Public Health. But it would be helpful for CDPH to be very clear on their website. Many of us refer many people to that website, and the information still is somewhat vague. If you just look at even 1A, BH is not called out. We've discussed it here. We've discussed it with the Drafting and Guidelines Committee. Everyone agrees that behavioral health is healthcare, but nowhere on CDPH's website does it say that. And if it doesn't say that, what we've heard from our other counties in the state is that behavioral health workers will stand in line to get their vaccine. It's their turn. We give them the letter from the Department of Healthcare Services saying it's our turn, and they're turned away by either their local hospital or their local public health department because they reference CDPH's website, which still says psychiatric facilities. That is the only mention of anything behavioral health. And so it would be very, very helpful to simply have a very simple message, I think, on CDPH's website that says all of the things we've been talking about, even pulling out that 65 plus is because they are dying at a higher rate. And I know there's a lot of information on the website, but for those of us who use that to guarantee or to try and get people vaccinated, it would be very, very helpful. Thank you.
Thank you very much, Ronnie. Christina.
Thanks, Bobby. Christina Mills from the California Foundation for Independent Living Centers. I just want to start by reminding all of us that we were invited to be a part of this group so that we could represent the communities that we work hard for in the community. And I think one thing that has been vividly clear through this process is that the data of people with disabilities is significantly lacking, and that there's been a very challenging time in figuring out if there is any research and statistics that we can use to actually prioritize people with disabilities. With that said, this process has made a lot of people with disabilities feel expendable and undervalued. While I understand the statistics that we are using and why older adults are being prioritized, many of us with underlying health conditions have been told by our healthcare providers that we would be more likely not to survive if we had COVID, or that we would have additional medical issues if we were to survive through it. Many people with disabilities depend on caregivers and other forms of long-term services and supports. So regardless of sheltering in place, we are constantly forced to put ourselves at risk as a quality of life issue. Healthcare rationing is a reality for our people, and we need to not penalize those of us who are at risk because we're not over 65 but do have underlying conditions. I want to applaud the counties that understand our issues and are actually prioritizing people with disabilities and understand the medical vulnerability involved. We should, as a committee, be lifting up those counties and showing their best practices, especially those who are doing mobile clinics and curbside clinics. I think the counties are much further ahead than we are, and I think that it's a missed opportunity to bring in some of the communities that are doing fantastic work and doing the right thing and prioritizing communities that really should be prioritized.
Thank you, Christina. Let's go to Amanda and then to Ron Fong.
Thanks, Bobby. Hi, Amanda McAllister-Woolner, she, her, hers, with the California LGBTQ Health and Human Services Network. Really, happy to see the emphasis on operationalizing equity and the addition to the place-based approach. I think, one thing that would make me feel even more excited about this and even more confident in this moving forward is to have more of a plan around how we're going to evaluate the success of this approach. if we're using HPI to allocate, 20% or some percentage of doses, how are we tracking specifically those doses that were allocated using HPI? How do we know what percentage of those have actually gotten into the arms? How do we make sure that those were actually, given to people who live within those zip codes or work within those zip codes, if that's also included in, in the definitions? How do we make sure that we're able to move nimbly if we're finding that we're having low rates of vaccination in certain zip codes? Right now the vaccination data that the state is providing is relatively high level, and so if we want to be able to break it down by zip code, if we want to be able to take equity really seriously, we need to be able to track that and monitor that to give us the information and tools to continue to adjust and continue to prioritize communities of color, LGBTQ communities, people living with disabilities, and others who are disparately impacted by COVID.
Thank you, Amanda. Let's go to Ron, and then after Ron to Susan Bonilla.
Thanks, Bobby. Ron Fong, President and CEO of the California Grocers Association. Thank you for all of the great insight. We do have an opportunity to implement an occupation-based or a place-based vaccine distribution system in grocery store pharmacies, and I think we're missing an opportunity here. We're talking a lot about CVS and Walgreens as the two retailers that are distributing, but the California Grocers Association has a request into CDPH to open up 1,000 grocery pharmacies that are ready, willing, able to start distributing as soon as you say yes. And these are large companies that operate pharmacies: Costco, Albertsons, Raley's, Save Mart, and Ralph's. We've got a tremendous opportunity here. The state registration system, the new one, is a challenge, and we're having a lot of difficulties getting our registration in. So be happy to work with whomever to get that system more efficient. But vaccinating our own grocery workers in our own pharmacies makes a lot of sense to me. They don't have to go stand in line at Cal Expo or anybody else. Just go to your pharmacy and vaccinate essential workers in grocery stores to take care of a population that has been serving our community since March of last year. Like farm workers, we've never closed. And it makes a lot of sense to me to vaccinate these essential workers so they can stay safe and we can continue to keep grocery stores open because we need them in our communities. And finally, to that point, I don't think I understood last week or the last meeting when we decided to include the 65 and older, that they would be prioritized over essential workers. I think that's a mistake. I think there's a better way. Grocery store workers are under tremendous pressure from our local governments to stay safe. And in fact, today, there are at least 8 to 10 jurisdictions in local government that want grocery stores to give hazard pay because grocery store workers are frontline. We'd like to avoid that. The better solution, I think, is to get grocery store workers vaccinated safely through grocery store pharmacies, and then we can continue to serve the rest of our community by opening it up and vaccinating everybody. So thank you for the opportunity of listening from the grocery store perspective.
Thank you, Ron. Susan?
Well, Ron and I didn't plan this together to ask our questions back to back, but I'm the CEO for the California Pharmacists Association, and we have members working in those grocery stores. And also what we could add is the existing network to the 1,000 grocery store across the state, are the over 800 independent pharmacies as well. So just really want to encourage, as we're talking about logistics and operationalizing, again, we have an existing network that is there, brick and mortar in neighborhoods, workers that speak the language of the neighborhood within walking distance of many of our most underserved patients and residents. And yet what we're finding is from county to county, most of our independents, I've heard of one independent pharmacy, maybe two that have an allocation. So it's critically important, I think, for us to consider, particularly with our older populations, to make sure that allocations are going to all of our pharmacies, whether they're in a neighborhood independent setting or in a grocery store setting or other retail setting. It's critically important, I think, on the equity front, on the age front, and as to Ron's point, on the worker front as well. I will say too that the Board of Pharmacy has approved mobile clinics, which would allow our pharmacists, once they have an allocation, that they could actually go to a school district or to a place of work and help on that front as well. And again, a mobile clinic doesn't mean they have a van. It means they don't have to function only in a licensed facility. They can go somewhere else to actually be giving the vaccination. So again, please, let's not make the same mistake we made with testing and delay getting our current network of health providers the access they need into the system, enrolled, and then when the allocation comes, they can be ready to go. Thank you so much.
Thanks, Susan. We have time for one more comment. Jeffrey Reynoso from Latino Coalition in this section, and Sylvia, we'll see if we can pick you up later in the meeting.
Great, thanks, Bobby. Jeff Reynoso, representing the Latino Coalition for Healthy California. It's such a difficult conversation. I'll start with Latinos are the only group where we've reached over 1 million cases, 1.1 million cases, double that of white Californians, nearly 15,000 dead. This is such a sobering time for our community. I think the thing that came to mind around this concept of operationalizing equity, if we think about the Bar-High framework around health and equities, I think there's a confusion between individual level morbidity, mortality outcomes and risk, and a health inequities framework, which is really looking at place, right? We often say zip code is a greater predictor of your morbidity and your mortality than your genetic code. And so as we think about operationalizing equity, particularly as it relates to the Latino population, we supported this framework around the essential workers because we know that is producing the greatest risk in our community. So farm workers, meat packers, grocery store workers, those in trucking and distribution. So we are very concerned with prioritizing age over the other, and a more integrated approach would be useful. In terms of how we reach the community, and if we think about operationalized equity and the interventions at a zip code level and prioritizing vaccines, then similar to Kieran's point previously, the vaccines, it should be flipped, right? So 80% of the vaccines should be going to the zip codes with the greatest level of risk. So I really encourage us to think about equity being at the forefront of how we operationalize this. And once the vaccine has been identified to those zip codes, thinking about who are the providers that are serving those communities most impacted. So I'll raise the community health centers. We know that community health centers are reaching the Latinx community. They are disproportionately the providers of first resort for our communities, undocumented in particular. So I would really encourage us to prioritize allocation of the vaccines for our community health center population, and then also thinking about alternative places of care. Cal Expo is great. I don't think Latinos necessarily go to Cal Expo. We may be at a swap meet, we may be at a supermercado, right? So I really think we need to think about more creatively of how we reach our Latino communities in particular. And so, we have a big task ahead as a state, but I really am encouraged by this work around operationalizing equity and would love to continue the conversation.
Thank you, Jeff. Great points. Nadine, back to you.
Thank you so much. And thank you all for all of these thoughtful comments. I think this is the process that we were hoping for, to really hear your best thinking and to hear all of your concerns and what matters to you and how you feel we should be thinking about this. So as we move forward, we also wanted to share, we've heard a lot about community engagement, equity, and vaccine acceptability. You set me up perfectly for that, for this next phase that we're going to do. And so we're going to hear a little bit more from our teams, Marisela Rodriguez and Marcela Ruiz, about some of the community outreach and engagement. Marisela, do you want to jump in?
Yeah, can you hear me now? Sorry, I think my AirPods were not connecting.
Yeah, we can
yes,
hear.
Bobby, give me a green. Okay, got it. Thumbs up from Bobby. So Bobby, as I get into this, you tell me how much time I have. I have a couple of things I wanted to do some show and tell with, and if I don't have time, I will want to prioritize. So we can go into the next slide. And again, just thank you for your time to give folks an update from the last presentation. So wanted to give a quick update and do some follow-up from some of the discussion we had last time. Just wanted to reiterate, these include some key messages. Some of the content that I'm going to show you includes some of the key messages that have been raised by this committee. This is including but not limited to, but just wanted to just put them up at the top. Safety and effectiveness, no cost, keep wearing a mask. And I said that these are including but not limited to. We have been able to roll out 2 PSAs, one in English and one in Spanish. And some of you may have already seen them. And for those who haven't, I actually did want to show that in the next slide. Is featuring one, our great Surgeon General, and the other in Spanish, Dr. Aragon. We also wanted to be able to move really quickly and engage other communities in different languages. And so I had mentioned that we were going to be jumping into what are called live reads so that we could reach 18 different languages, 40 media outlets. I do have an audio file that I can play so folks can hear how those have been picked up and are currently playing. And then just another follow-up that we continue to work across different partnerships to, again, with that storytelling piece, the testimonials of folks that are doing the work of vaccinating, as well as those that are getting their vaccines, talking about the safety and why it's important. That storytelling component from Trusted Messengers is super key to our strategy, and that we continue to do that work. So can go into the next slide. And then hopefully, if it doesn't play, we have the link for you, Bobby.
No, we tested it. Should play. Takes a second, I think.
Okay, and so thank you again to Dr. Aragon. You gave us, I think, one of your Saturdays to help us film this. And again, this covers a couple of the key messages of safety, no cost. And
las vacunas de
doing both
COVID-19
English and
están
Spanish.
aquí. Son recomendadas por expertos médicos de California porque se ha comprobado que son altamente eficaces y estarán disponibles sin costo. La vacuna de COVID-19 puede ayudar a protegerte a ti y a tu familia y acabar con la pandemia. Y recuerda, sigue usando mascarilla aún después de vacunarte. Para más detalles visita vaccinateall58.com.
And just wanted to highlight also one note that we added to the script was the mention of, it's not just about you, it's about protecting your family too. And I believe that was a comment that was raised by the committee last time, and also shows up in the research that Martha presented on last time, and that we continue to find as an important message for the Latino population. So can go to the next slide. And then this is just a fun way to present the data on our reach. So Bobby, if you can hit the link, I can talk through it. Wanted to show you the different communities that we are reaching, the languages that we are reaching, and the number of different outlets. I believe we're about at 76 different media outlets, and this covers our paid media reach. And so it's just a fun 15-second animation.
I don't think the link is here.
Different
slide?
If it's, I think I sent it as a separate link, but can move on to the next slide if you don't have it.
Yeah, let's move on.
Apologies if it got lost. Wanted to also just, last time we mentioned we were also going to ramp up our earned media efforts. And I guess before I jump into the earned media, I want to say that the work that I just showed you is what we've been able to accomplish. It doesn't mean that we're done. We want to continue to create pieces of content that can speak to specific issues that are coming up that, again, press on some hesitancy issues and concerns, and can continue to look at specific messages and approaches that will resonate with different populations. So we are still creating additional content. Just wanted to do a follow-up from the pieces that we had mentioned that were in the works in the last presentation. So as we look at earned media, we mentioned we wanted to ramp up and wanted to give you a snapshot of what that looks like. We are looking at earned media to continue to reinforce what the facts are, again, pressing on the key messages, as well as highlighting some of the new developments in the vaccine work, and then addressing any myth and disinformation. Next slide. And you'll see that in the next two slides, we have some samples since December, we've been able to produce about 80 different pieces of content related to earned media, getting a lot of different trusted messengers out there. Can show the next slide too. Thank you. So working with a broader list of trusted messengers who are helping us cover local media, ethnic media across the state. Appreciate our Surgeon General and Dr. Aragon, who are giving us a lot of their time. I think we're at a cadence of almost a daily basis of trying to give in real time updates to the public as much as we can. We want to be able to keep pace with information that's flowing and be able to address questions that are coming up for the public. Next slide. And then something that's coming up is that we wanted to do a media briefings, and we have a couple that are just this week. They are going to be virtual. And so if there are media outlets you would like us to consider, please send them our way. We'd be happy to invite. There isn't really a limit right now in terms of how many folks we can invite. We want this to be strong in our reach, so we welcome feedback on any media outlets you would like us to include. And we are working with different partners to help us with this work, including California Black Media, Ethnic Media Services. We also plan to do more in the future, including partnering with NUNAT, who will help us with our Native American population. So really being intentional about our reach to focus on the populations that are disproportionately impacted. Next slide. In this slide, I wanted just to give some context. We know that part of the questions that are being raised right now include, how do I access the vaccine? Where can I go for help? So in no way is this slide meant to be a final product. I wanted to show it to you because this is something that we are thinking about. How can we respond to the question about what are the different pathways for folks, as using the folks that are 65 and above as an example, how could they access the vaccine? And so we know for now that these are the different pathways and different profiles, I would say, for different people. So wanting to think about how do we address the question, how do we outline in a clear way So this is just a starting point for us. We wanted to let you know that we are thinking about this. We want to figure out how to make this a simple piece of content for folks, and this is our starting point. We also know that folks need help that is not only online, and that people need help over the phone or in person, so we're thinking about those things. Next slide. And as we go into the next slide, I wanted to mention that one of the things that was really successful for our census efforts was working across our different departments and agencies who work with populations that we were targeting, who were considered hard to count. In this case, looking at folks who are disproportionately impacted and hard to reach. And so there are programs and services that folks count on where we would like to establish partnerships, integrate messaging, have already started conversations with a few folks, including Listos. Listos has a tremendous reach with the work that they've been doing over the last year with the same folks that we're trying to reach. And so we're starting to do that legwork now. And so we want to establish partnerships both inside state government as well as outside state government who can help us reach older Californians. And then as we look at our targeted paid and earned media, also thinking about that and being intentional. And one note for the folks that are 65 and above, not only just reaching them directly, but also families. If I'm sure that there are a lot of families like mine where I'm the one that helps my mom with her health coverage every time that she has a question, helps her enroll, helps her answer questions. And so we know that family is important both as a trusted messenger and also someone who helps folks navigate systems. So want to make sure we're reaching families as well. And then I think as we go into the next slide, it might actually be going into our community outreach work, and can hand it over to Marcela.
Maricela, this is Bobby. You know, we had a clip on one of the earlier slides that we didn't show. It was one of the ads that you have. Did you want to show that?
Sure, let's go ahead and share it.
We can go back to the slide that has the video on it. It just takes a minute, but I think people might like to see it. That one right there.
We've been doing our part to slow the spread of COVID-19, and now there is a light at the end of the tunnel, a safe and effective vaccine.
A vaccine means we can restart our economy, open our schools, and visit with our families.
I hope that you join me in celebrating this moment.
I'm definitely taking the COVID-19 vaccine because too many friends and family have died. And I'm afraid that my family members will be infected with the COVID virus. A virus that we will not be able to get rid of unless all of us are vaccinated.
Let's stop COVID in its tracks. I'll be getting my vaccine, and I hope that you will too.
And that was just a quick compilation of the different pieces that we've worked on with the different partners. And, you know, at the end of the slide, we have the link to our COVID toolkit website where we house a lot of this content and have a special link for partners. So, you know, we try to make it easy for folks to just be able to pick up the content and use it on their own. Thank you, Bobby, for that. I'll go ahead and turn it over to Marcela.
So hi, good evening, everyone. First of all, I would just like to start out with an appreciation for inviting me into this space and also for all the work that so many of you are already doing in terms of COVID outreach. We have partnered with many of the organizations on this call on other projects, and we know how committed you are to the communities that are disproportionately impacted by COVID. So thank you for all of that work. My name is Marcela Ruiz. I'm the Director of the Office of Equity with the Department of Social Services. And last week, you heard an update from Marisela Rodriguez about the COVID Outreach Project. Today, we wanted to take an opportunity both to provide you with an update on that project and also to share more broadly with you the framework for the community engagement components of the outreach work that the state is currently involved in. So we're really thinking about the community engagement efforts as focused on individuals disproportionately impacted by
by COVID-19 through that equity lens that many of you have lifted up throughout this conversation. And we're thinking about it as having three separate pillars. One of them, a critical one, is stakeholder engagement. So these types of efforts, statewide efforts to engage community, as well as maybe department-led or agency-led efforts to engage stakeholders that are unique to particular departments. There's also a component that's a philanthropic partnership that is also focused on funding community-based organizations that are providing outreach to disproportionately impacted communities, as well as ongoing fund development that is being coordinated through the governor's office. And finally, there's the public funding component, which is both happening at the local level and then at the state level. And we'll talk more about the state level funding in just a moment. Also just wanted to share with you that overall, the goal of all of these efforts is, one, to build capacity through investment. We know that the communities that are disproportionately impacted by COVID are best reached by trusted community-based partners like yourselves. We also want to leverage existing networks and partnerships. The state certainly learned a lot through its census partnership, and we are leveraging a lot of that infrastructure and those partnerships that made the count so effective in California. And also in partnering with philanthropic institutions, we are leveraging those partnerships that they have and activating the community-based organizations that have reach into community. We want to coordinate across these efforts as much as possible to ensure maximum coverage and engage in meaningful partnerships. So once again, at the highest level, it means this kind of conversation where you share your input. I think we'll talk more about what it looks like in terms of the funding that we'll be administering, but we're really looking for a partnership that informs the strategy, the tactics, and the policy for how the programs are rolled out. Next slide, please. So as a reminder, the California Department of Social Services and the Labor Workforce Development Agency, we are jointly administering an investment of $30 million to fund community-based organizations to focus on outreach to disproportionately impacted populations. We are working through philanthropic institutions to contract with community-based organizations. The outreach is going to focus first on providing accurate information to those populations around the vaccine, around public health guidance, and also around labor rights. The second component of the campaign is to help people navigate toward those resources. So to the extent that we're building the infrastructure to connect people with the vaccine, or we are building the tools and the information that people have to ensure that they can enforce their rights at work, there will be mechanisms to help ensure that we are connecting folks with those resources. The outreach is expected to be digital, online, trainings online, also in-person phone banking, canvassing, again, many of the same strategies that were used during the census outreach. My colleague, Emilio Vaca, will provide an update of where we are in the process with the state-funded investment. But first, I want to speak about our key philanthropic partnership with the Public Health Institute, or PHI. So for that funding, the governor's office, in coordination with the Department of Public Health and with Social Services, is working closely with philanthropic partners on a pooled fund of $27.5 million to support COVID response. The fund is being administered by the Public Health Institute, PHI, in coordination with the Department of Social Services, and will also be used to fund CBOs to promote public awareness on vaccine. This fund is also focused on disproportionately impacted populations. PHI is identifying CBO partners that are supporting enhanced communication and education to increase the adoption of behavioral change that will lead to the reduction of the spread of COVID-19, including vaccine adoption. The invitations to apply for the funding, for the PHI funding, are being distributed on a rolling basis. And I'll just stress that while this is not an open process for PHI, if this committee does have recommendations of CBOs who are well positioned to educate communities about vaccines, we invite you to please send those ideas to Bobby and her team, and we will be sure to share that information with PHI. And so with that, I am going to hand it over to my colleague, Emilio Vaca, who will share a little bit more about where we are with the community outreach campaign.
Thank you, Marcella. Good evening. Thank you, Dr. Burke-Harris, Dr. Pan, and Bobby for the kind invitation to be part of tonight's meeting. And it is so refreshing to see so many familiar faces. My name is Emilio Vaca, that was currently am still the Deputy Director of Outreach for the Census Office. And so I have a great admiration of folks that I see on here, Deep, Lisa, Genevieve, Christina Mills as an example. Just super glad that you're also part of these discussions. And as we move forward with what Marcella and Maricela have shared, is really looking at what are the things that we learned from census? What are the key takeaways? And one of the things that we really were able to leverage on was the trusted messengers. And I think that's something that you'll begin to see across the board with all of this messaging and also with outreach. And so I'm super excited to share that, you know, as Marcella mentioned, you know, we have the first cohort of our partners here. We're aiming, I know that Maricela in the last week's presentation mentioned that we're aiming towards 150 organizations to conduct outreach across the state and looking at those specific populations. And as of right now, we're looking as of the 24th of this month, at the end of this week, we will be announcing 91 partners who will be joining us on starting to come on board and do onboarding the first week of February, so we can start conducting outreach later on. And then the second cohort is in the coming weeks, we'll be sending invitations to organizations to focus on LA, Orange, and Ventura counties to help with outreach as well. So once again, just want to say thank you for the time and the space for letting us be here to share. As before, we also want to thank, I know last week Maricela asked if folks had individual entities that we should invite, and just wanted to say thank you for those advisory committee members that came forward and submitted some of the organizations to invite. So thank you with that. And I don't know, Marcella, if there's anything else that you think I might have left out.
No, thank you, Emilio. I think you covered it, and happy to answer questions.
Great. We have a number of people who have comments to make. So if Nadine, if you're okay, we'll just get started with that.
Please, thank you.
Good. So let's start with Sylvia Yee, and then we'll go to Denny Chan, Orville Thomas, and Aaron Carruthers.
Hello, everyone. I'm Sylvia Yee. I'm with Disability Rights Education and Defense Fund. Thank you. I appreciate the pieces on community engagement. I think it's wonderful to hear and such fantastic work. I'm sorry that the comment is only peripherally attached to that because I'm sort of a holdover from the last one. But I wanted to just acknowledge, I know that everyone is working really hard, from the chairs down to all the committee members. And when I applied to be here I recognized that it was part of my job to be working for everyone, for all of California as such. And a lot of the questions I've been asking from a long time ago on implementation, how things actually, what's the relationship between the counties and the state and how the rollout actually occur, have been meant to be broad, to apply to everyone, because equity is inherent in the barriers that will occur at implementation stages. But at the same time, I'm also here to represent the disability community, and it feels like we're just still that much behind, because even talking about community engagement, we're not on the list. There is no disability category or group that's explicitly on the list. It was great to see the IHSS worker in there, because as Aaron wrote, in the comments, IHS workers are being turned away, being told that home healthcare is not a thing. So it's critical for IHSS workers to be there. In the messages, we don't necessarily see a younger person with significant disabilities because they're not, again, they're not on the list. The fact of exposure because they get home and community-based services, the fact of more severe consequences because of having disabilities. If they're not in the list, they disappear, and that perpetuates a long-lasting inequality of data. I don't, there's no other way. I know I just sound like a broken record, but I don't know how else to raise this besides with my voice and with research and with communications. We're just not there. And okay, so the broken record thing. Simplicity, working at the site. I appreciate Kieran's suggestions about having counties add to the Healthy Places Index by recognizing particularly vulnerable groups like Indigenous populations and people with disabilities. At its core, though, I just don't think that that should be a local county decision, which is going to depend on how many advocates are in a county, how strong they are. It shouldn't be left to chance like that. If California values everyone in California, it has to value its people with disabilities. And we've put forth a proposal that looks at specific individuals that are most at risk. So that's all that's it. Thank you.
Thank you, Sylvia, and don't turn the record off. It needs to continue. So thank you. Let's go on to Denny Chan.
Hi, everyone. Thanks, Bobby. Denny Chan from Justice and Aging. Sylvia is a hard one to follow, plus one everything she said. But I had a couple of other thoughts that I wanted to raise, some of which apply to this issue of community engagement, and some of which are a holdover from earlier conversations. I think we at Justice and Aging believe strongly in prioritizing older adults who are more likely to be at risk in 1B, and we made that decision that recommendation very comfortably with frontline workers, essential workers. I would encourage the state not to prioritize all older adults over all essential workers. That sort of broad brushstrokes approach is going to not result in the equitable outcomes that we all desire. I think instead we should really be thinking about how do we further sub-prioritize in 1B? What are the specific intersections that we want to make sure counties are considering when they're allocating the vaccine? I will completely agree that an older adult who has the resources and ability to order from Costco and Amazon and shelter in place and not have to interact with many other people probably can wait a couple more weeks or a month or two before they get the vaccine. But there also are a number of older adults who have been sheltering in place and whose health has been compromised because of that. They have foregone important community services, and that has taken and will continue to take a toll on them. And so one way that the state can immediately elevate that population and not split disability and aging advocates is by prioritizing home and community-based services recipients. We know that is a high-risk population, and I'll be the broken record on that one, that should continue to be a priority population in 1B. I also think it's really important that when we're talking about older adults, we're not talking about a monolith of 65 and up, just like we've said about risk not being the same for all older adults. I think the outreach and communication strategies need to be tailored. There's going to need to be a strategy for people with Alzheimer's and dementia and caregivers. There's going to need to be a strategy for older Black adults. So that, I realize you came to us with one screen, one slide on all of that, and that's a work in progress, but I would hope that at our future meeting, we can see more of that fleshed out. And then finally, I want to say just a couple of things about the how. I don't feel like we've had a very complete conversation about the how. And the how is really important because no matter how much time we spend on the priorities and who should be in 1A and 1B, if we aren't putting shots in arms in a way that makes sense, that those conversations are not going to be as impactful. I wanted to share one story because it's related to language access work that some of the last speakers touched on. A IHSS worker reached out. I heard about this story and reached out. They got a shot. They got the Moderna shot earlier last week. They're a monolingual, I think, Chinese IHSS worker. So they fall right into 1A. They didn't have problems. They weren't turned away. So that was great. They didn't know how to get to the testing site or the vaccine site, but they found a friend who could take them. It all worked out, except the instructions that she received about post follow-up shot was all in English. She didn't know that she needed to go back and schedule an appointment 3 weeks later until she found someone at a CBAS center who told her that and would work with her to schedule that appointment. So when we're talking about not wasting the shots that we have, I mean, this is all about the how. So we can't squeeze these conversations about the how to the last 15 minutes of the meeting. If that means that we need more time, I know these meetings are long, maybe we need extra breaks, I don't know. But I think the how is really important. And these are challenges that we've known about. We know this is a hard to reach population. We haven't even talked about how to get to homebound folks. You know, Cal Expo is great. We talked a little bit last time about mobile testing and the limitations on, or I'm sorry, not mobile testing, mobile vaccinations and the limitations on that because of the cold chain storage requirements. But that can't be the answer. That shouldn't be the end of the inquiry. So I have a deep appetite to continue to engage on the questions of how. I sense that my fellow colleagues on this committee very much do. And so I really hope at our next meeting, we can not only get a robust report and Q&A on the federal partnership, because we haven't even really gone into the weeds on that, but also that we spend some really prolonged time on the how. You have a lot of expertise on this committee, and I really encourage you to leverage it because these are real-time issues that we can't just cabin in the last 20 minutes. So thank you. I'll stop talking.
Thank you, Danny. Orville.
Yeah, hi, thanks everyone. Orville Thomas, the California Immigrant Policy Center. Really echoing what Denny said, we really devote more time needed to talk about it, especially considering that stakeholders are part of the public outreach plan, and we can be so helpful given the populations that we all represent and the history of relationships that we have in our organizations. I look at this, in addition to the census, also the way that we attack the public charge crisis that was seen throughout the state and our immigrant communities. And my concern is that, like the census, like public charge, the longer that we aren't getting these informations out into the community, the harder it's going to be. We saw with census that it takes a handful, if not more, of touches to make them comfortable with this work. We see with public charge that there is a lot of miscommunication and misinformation. And that also happens within the state government. So when I see that list of all the organizations and agencies, each one was saying different things. So I would like there to be more answers maybe given to us, one of why priority or cohort 2, it had a listing for, kind of Los Angeles counties. Is there going to be a prioritization for the farm workers in the Central Valley, Monterey, Salinas, like all of those areas? Like, are we going to get that in cohort 1? When do we get to see a list of the organizations? Are these organizations that have a history of the One California network? Are they working with, health access and our opportunity to complete the health for all kids, health for young adults, having those trusted partnerships? How long are these ads running? What does the campaign look like? Is there social media? Is it going on things that, our ethnic monolingual communities are using, like WeChat? Are we seeing all of these trusted partners in that area? So, really appreciative of the effort, want to get so much more information. I think that's to Denny's point too, and hoping that the next time, if we can't finish up with 15 minutes, we get to devote way more of a conversation to communications. And, to the last part where we have workers that are maybe monolingual, we really have to focus on having workplace vaccinations. And does that mean that we could reduce maybe some of the paperwork necessary, whether it's pay stubs, that some of our immigrant workers may not be able to have as easily accessible to get that vaccination for their essential worker status? Thank you. Looking forward to more conversation.
Thank you, Aaron, for enforcing what Denny brought up. Nadine, I think that's it for our comments, and I think we're at the end of our time and ready to wrap up the meeting.
Thank you so much, Bobby, and thank you to all of you for your continued engagement. Today on today's meeting, I think we had all but 2 of our members present. So thank you very, very much. We know that you all are very busy in the important work that you are doing every day, and the fact that you make time to participate and lift up your voice and share the experiences and represent the concerns of the communities that you represent is just really powerful. We're very, very grateful for it, and it certainly enriches our process as a state. I started this meeting by sharing with you all that we are hearing it. We are hearing all of the challenges with the current vaccine distribution system, and that we are working to improve it. Some of the things that we are hearing are consistent with things that we are hearing that we've heard again in this meeting around the important need for clear and consistent communication to create to help to manage expectations. And we're hearing the importance of reaching out to communities in the many different ways, particularly in language, and reaching out to having a thoughtful plan and strategy for reaching out to our communities of individuals with disabilities. I want to summarize some of the key things that I'm hearing from this meeting is that as we are considering how to simplify our vaccine allocation strategy or simplify this process, one of the things that I'm hearing overwhelmingly is that this committee feels like the sector-based strategy that we have employed and landed on is really crucial, and is really crucial for advancing issues of equity. It's crucial because of issues of occupational exposure, which is what we heard about, which was really part of the foundation of how we designed our system. And so that piece feels really important. But we still have work to do to simplify and clarify. And what we heard from what I heard from this committee is that there are a couple of pieces that are really key. One is this last mile issue in terms of increased attention to how we are operationalizing getting shots in arms, especially for vulnerable communities and sectors that are typically hard to reach, like the farm worker community, and figuring out really getting more clarity on how do we problem solve some of the challenges that we have in that last mile issue. And then also getting further clarity on how we are getting clearer detail on some of our communication strategies, because, you know, as we have our public health officers, so many of our healthcare workers, our leaders, our partners, our advocates across the states, our community-based organizations who are all have their sleeves rolled up and are really part of this effort. A lot of the challenges, a lot of the pieces around how is it working at point of care, right? In terms of operations, in terms of communication, in terms of follow-up, all of those pieces are really key details that this committee has some thoughtful suggestions to share with us. We're continuing to hear, and I want to highlight, we are hearing the concern for individuals with disabilities and the suggestions on ways that we can operationalize ensuring that individuals with disabilities have timely access. And then we're also hearing the desire, the need for greater data, right? And I recognize some of that we are working very hard in improving our data systems. And at the same time, I just want to, like, talking about, communicating clearly to set expectations, right? I want to recognize that one of the most challenging things about responding to a pandemic, a novel pandemic with a novel virus, is that we have to work with the best information that we have, right? And that is one of the biggest challenges, is that we're constantly gathering information, but we're also working with the best information that we have. And so my commitment to all of you, and our commitment is that all of this information will be shared and communicated, hopefully equally as passionately, to our drafting guidelines work group. We communicated to the governor's task force, and that all of the thoughtful considerations that you all have shared with us today will be passed on and considered as we are moving forward in the next phase of decision making on how to improve our vaccine rollout process for the state of California. Once again, we are all very grateful for your time, your expertise, your passion, and your level of partnership and collaboration. We're receiving the offers to partner and collaborate and communicate, and I just want to say, please continue sharing that as much as as much as we can. We try to respond in a thoughtful and timely way. And with that, I will highlight that we have our next meeting will be on February 3rd from 3 to 6 p.m. And then following that, the meeting following will be February 17th, also from 3 to 6 p.m. We're looking ahead at our March meetings and looking at, I think we have a final on whether we're having 1 or 2 meetings in March, but right now it looks like we've asked you all to hold 2 dates, and we may have 2 meetings in March, depending on how things are going with this vaccine rollout. So with that, Bobby, do you have any final comments to share with the group before we adjourn?
Well, thank you all so much for all your thoughts and your comments, and this is exactly what's needed. So please keep it coming.
Thank you so much. We are adjourned. Have a good night, everyone.
Thank you.
Thank you.
See you in a few weeks.
Thanks,
Thank
everyone.
you.